For those of you I have not had the opportunity to meet, I am Dr. Keisha Pierre. I'm one of your associate professors in the Department of Anesthesiology and one of your unspoken physician champions for multimodal pain management. So this lecture has, it's sort of evolved. It started out as a kind of the informal resident lecture. It's now titled Grand Rounds. I think I would consider it more of a fireside chat. So I love the fact that you guys are seated sort of informally. I think that'll fit well with what we're doing. It's not going to be heavily laden with literature citations. The goal of this lecture really for you is to just be able to get a really good grasp of the continuum of the depth of anesthesia, sort of what we offer in terms of the spectrum of anesthesia care, what monitored anesthesia care or MAC is and what it is not, and just as a focus of helping to improve the communication in terms of what you need and your expectations intraoperatively. And then lastly, based on the discussion that Dr. Jenkins and I had, really talking about multimodal anesthesia, just introducing you to some of the medications that we use and implement just as a means of managing your patients and ensuring that they have better outcomes for you. I have no disclosures nor conflicts of interest for this talk. So we are all experiencing this production pressure of kind of faster turnovers and rapid recovery. So that's why this matters. You guys are being asked to do more within your short block and window of time. And so the expectation for us is to ensure that the patients are not only safe during the procedure, but also that they're recovering rapidly, they're emerging rapidly. And then our same-day surgery area and our post-operative area at East Jefferson, it's a really small footprint. And so for us, we're also tasked with ensuring that the patients are recovering quickly and that they're moving on to the next phase of discharge in a relatively efficient manner. And then we want the patients to go home, stay home, and do well. And so hence we enter into this increased demand for lighter anesthesia that sometimes is just globally labeled as MAC. And really, sometimes the MAC that you need really isn't a MAC. It's deep sedation or really general anesthesia without an airway. And so when we are not planning appropriately as anesthesia providers, when we're given the term MAC, sometimes we are unexpectedly tasked with sedating the patient deeper than we initially planned. And then that's where we enter into really kind of compromising safety in some of the patients. So what are the ASA definitions of sort of what we call anesthesia? Minimal sedation, moderate, and deep sedation are going to fall in what we call a MAC category. So minimal sedation, the patients really should be able to respond very easily. They should be very lightly sedated. You should be able to speak with them and not have any issues with stimulating them and getting them to response. Moderate sedation would be more of your patients that you maybe need to call their name and tap them sort of to arouse them. And then deeper sedation, some of you have seen this while we're emerging patients or even some of our patients that are sedated that we're trying to get to respond, sort of the deep sternal rub to get the patients to respond. That would fall more in that deep sedation category. And then general anesthesia is where a patient is not responsive regardless of the depth of stimulation. And with the exception of general anesthesia, where a patient is paralyzed and a patient's intubated, patients will move really along this spectrum or continuum between moderate, minimal, and deep sedation. It's very, very subjective. It depends on the patient themselves, their sensitivity, and some of their medical issues and age as well has a really a huge impact on how sensitive our patients are. And so, as you can see, it's important for us to plan appropriately because you have different physiologic responses with the depths of anesthesia. We know that most of the medications that we give for anesthesia sedation, essentially we're using the same medications, and very often it's the amount of the medication, the dose of the medication, and then sort of some introduction and some of the multimodal that we'll talk about. But the medications, most of what we give, they're dropping the systemic vascular resistance very often. They're relaxing the patient, but they're also relaxing the blood pressure. And some of these patients, especially the patients patients that are have cardiovascular underlying diseases, issues, that has a really great impact on those patients that we end up sedating deeply and aren't necessarily planning for supporting the patient's blood pressure with things like norepinephrine and epinephrine. A lot of the drugs that we use as well, they cause respiratory depressions. So patients will very often breath hold with higher doses. So these escalating or increases in the amount of anesthesia or the depth of anesthesia, it's important that we are communicating appropriately sort of what you need. We're matching what you need, and we're planning appropriately for patients based on the depth of anesthesia. So by definition, what is MAC? MAC is essentially anytime an anesthesiologist steps into the operating room with you and it's not general anesthesia. So general anesthesia, again, the patient's not responsive at all, and very often we have to support their airway. With MAC, I can step into the operating room and let's say our interventional cardiologist may just want us there to not provide sedation, but to monitor patient's hemodynamics. That's considered MAC anesthesia, but it ranges also to sort of that deep sedation as well. So MAC isn't defined by the depth of anesthesia necessarily. So it's important for us to be able to kind of communicate exactly what you need in terms of a urology anesthetic. So what is MAC not? It's not, again, just a little sedation, because it can range. It's not necessarily safer than general anesthesia. I think that's probably one of the biggest myths. And the patients aren't necessarily breathing spontaneously and breathing well when we get into those deeper planes of anesthesia. If you give me a choice as an anesthesiologist and you say, hey, you can choose between general anesthesia and MAC, I would choose general anesthesia every time. There are some patient-specific factors that would increase the risk of MAC versus general. But for the most part, general anesthesia, I know that I can get that patient into the deepest plane of anesthesia. I'm going to have drugs, medications to be able to support the blood pressure, but most importantly, I'm going to have an airway to ensure that I'm able to manage the patient's ventilatory status. MAC, it's sort of a touch and go. MAC is very, very subjective. And so we really have to figure out where the patient falls on the MAC scale to be able to determine how much they need, how deep they need to be able to really kind of match the stimulation. And so MAC, I find it requires much more effort, much more intention in terms of finding the perfect MAC, where you have a patient that's not really readily responding to all of the surgical stimulation. They're arousable, but they're still maintaining their airway. That's much more tricky than putting in an airway and controlling everything. So when will MAC work well for you in urology? So your short cystoscopy patients, stent placements and removals, you guys have become really, really fast at those cases. Minor ureteroscopies, so fast ureteroscopies, and then a cooperative patient. So remember, with MAC, the patient has to be arousable. That's by definition MAC. So if I start out with a patient that's demented, a patient that's confused, a patient that's combative, then that's not a patient that's not going to necessarily be an appropriate patient for MAC, because at any phase of that procedure, that patient could, again, arouse to the point where they become uncooperative. When does MAC anesthesia actually become really unsafe? So for the long ureteroscopy patients, short stimulation, the viscous lidocaine, that can often get us through sort of those short bursts of high stimulation with the ureteroscopy. But for the longer cases, it becomes much more difficult for us to continue to sedate those patients and to keep them not responsive to us, but not responsive to the surgical stimulation. So anything with really high stimulation, like lithotripsy, it's not going to be appropriate for MAC. Obese patients are really large patients. So some of these patients, especially the ones that are sleep apnea patients, the patients that are really not well managed in terms of their obstructive sleep apnea, those patients often have daytime somnolence. They're extremely sensitive to some of our sedating medications. And very often you just give a patient any medication and they drift off to sleep. Those patients will obstruct. And so when the patient obstructs, they become hypoxic. They become tachycardic and hypertensive. And so we go down this long physiologic sequelae just based on the fact that they're obese patients. The other challenge with obesity and also the prone and steep lithotomy position is when we're displacing these patients or when the patients are lying flat, we're relying on them to spontaneously ventilate during MAC. And so when they're lying flat or we're in these steep positions, it really displaces the patient's abdominal contents and displaces the diaphragm so that it starts to compromise the functional residual capacity. That's the parts of the lungs that really participate in active gas exchange. And so those patients become at increased risk for hypoxia. And really, for some of them, it's just difficult for them to breathe spontaneously. So if, there's a planned procedure where we're going to be in those steep positions or steep lithotomy, those are patients that are not necessarily going to be the most appropriate for MAC. And so sometimes it's safer to just plan for general anesthesia early on. So for us, in terms of communicating and collaborating as a team, as a perioperative team, instead of just asking for a MAC, just share what you think this case involves. So if it's a case that involves, it's going to be a really short case, it's going to be low stimulation, hey, patient's going to be comfortable, as I have written here, with minimal sedation, then we know, okay, that's a patient based on their physiologic profile that might be an appropriate candidate for MAC, as opposed to, emphasizing to us, hey, this may be a little more complex, this might be stimulating. That way we can have a clear and appropriate plan early on. If we have a clear and appropriate plan early on, it's easy for us to match physiologically whether we need to be a deeper sedation or general anesthesia. It's easier for us to plan up front and have all the tools that we need to appropriately respond and apply the anesthetic that you need. The last thing that we want is to start with a MAC case, it becomes something complex, and you have a patient that moves in the middle of a ureteroscopy. So communication really is sort of the emphasis of you guys just sort of understanding what our spectrum of anesthesia is and what the options are for you. So whether our plan is for MAC or general anesthesia, our objectives together, right? They're going to remain the same. Bottom line, what do we want? We want our patients to be completely comfortable. We want them to be safe physiologically. And we really want them to do well long term. And so how we approach managing the patient's sedation and pain management really has evolved. We now enter into this sort of concept that's really been pushed, I would say, over the last 10 years, certainly of my career, of multimodal anesthesia. We know that pain, it's not a single pathway problem. So you don't have pain that just enters the central nervous system, and so you just address it at one pathway. We know that pain, the signal of pain, it's multi-level. And so instead of treating it as just a single pathway problem with a single agent, which traditionally was opiates, we now have this concept of treating pain at these multiple different pathways so that there can be less emphasis on just relying on opiates. We know that we're in a severe opiate crisis now, and we know that over-treating pain with narcotics, over-prescribing pain with narcotics certainly has contributed to the majority of the issues that we're now seeing with opiate overdoses. So we know that when we're over-prescribing for patients, it's going to lead to tolerance, it's going to lead to addiction, and very often it leads to diversion into the community. In addition to that, it will cause things like respiratory depression in those patients and the sequelae that comes along with hypoxia, and even some of the long-term sequelae, it can cause delirium in these patients. So we know by addressing it with multiple different agents, decreasing our reliance just on opiates, having this multi-tiered and layered approach, those drugs, they work synergistically with one another or additive effects with one another. And when we control pain, we know that we're producing better outcomes in those patients. So they're going to be more active. They'll move early on and prevent things like pneumonia and DVTs and postoperative cognitive dysfunction. So pain pathway, as I mentioned, multi-tiered. So it's going to start at the tissue level. It'll move through your peripheral nervous system to the spinal cord. And then you have this conscious experience of pain where you can have things up and down regulated in the brain. And so I'm just going to broadly cover for you guys some of the agents that we use, where they actually work and sort of this pain pathway so that you can not only have some oversight in some of the things that we're doing, but also maybe request if you notice that, you have some providers that maybe are relying a little bit less on some of our multimodal modalities and more on opiates. So this is just an overview of some of the medications that we use, many of which you have probably at least heard of or maybe even seen on the anesthesia record. So in terms of pain, the pain pathway, it starts with pain receptors, so nociception. So for you in urology, that's going to be things like your bladder and ureteral dilation or distension, any manipulation with the scope, some of your percutaneous lithotripsy cases, and even incision sites where you're placing your trocars. And so the medications that we will utilize that attack this pathway will be your NSAIDs and COX inhibitors. Local anesthetics, I would encourage all of you, if there's an incision that's made on the patient's skin, then I push all of you to use some form of local anesthetic. Lidocaine has fast onset, but think about Marcaine as well. Marcaine has a longer half-life, especially when it's used at epinephrine. You can get almost 24 hours of pain relief out of those incision sites, and everything matters. Acetaminophen is also going to work in the peripheral pain receptors, and then dexamethasone. So how do these drugs work? Most of them are addressing prostaglandins. So if we think about the pain pathway, you can think about substance P as sort of being the peptide that really perpetuates a pain signal. You can think of NMDA as either amplifying or decreasing that signal. And then you can think of prostaglandins as a substance that really kind of sensitizes the patient's nerves to having increased pain perception. So most of these drugs, all of the drugs, are going to work in some form around these receptors. For your NSAIDs and your COX inhibitors and acetaminophen, again, they're addressing prostaglandins. So we know that with prostaglandins, if we decrease their response, we're decreasing inflammation, we're decreasing our sensitization to pain. So that'll be things like Toradol, ibuprofen. There are actually IV forms of ibuprofen as well. I don't know that we have them at East Jefferson, but they are available. And then Celebrex is another one. Considerations with these drugs, long-term effects with these drugs, not short-term, but long-term effects with these drugs. We do have to be mindful. They do decrease that sort of protective lining that's formed in the GI tract. And so it can predispose a patient with prolonged use to having things like gastric ulcers, or GI upset. It does decrease platelet aggregation. Again, prolonged use will decrease platelet aggregation. And then the cardiovascular and renal risk that you get with prolonged use of this drugs has to do with the fact that prostaglandin actually vasodilates. And so when you block prostaglandin over a prolonged period of time, it causes vasoconstriction. And so the patients, again, that have myocardium at risk, that are primed for cardiovascular disease, and then your patients that have some underlying renal dysfunction, you have to be mindful of using this category of drugs in those patients. Tylenol, pretty safe when it's used in appropriate doses, limiting it to 4 grams per day in patients that have normal hepatic function. Otherwise, you certainly can venture into hepatic toxicity. As I mentioned, the local anesthetics, appropriate to use both on the skin surface, and also we use intravenous lidocaine. So we'll use intravenous lidocaine initially because the propofol or etomidate that we use, it burns, but we also continue to use it throughout a case, a prolonged case, because again, it decreases some of the central sensitization. One of the things that's important to note that if you have a patient that's in continuous pain, it decreases gastric motility in those patients, and so it increases the risk of an ileus in those patients. So if you're performing any sort of intra-abdominal procedure like a nephrectomy or partial nephrectomy, that's considered consideration, controlling pain is really going to support the patient's bowel function returning sooner. And then dexamethasone or Decadron, again, decreases prostaglandin, so decreases the priming for the patient to have that sort of ramped up signal of pain. So from the peripheral nervous system, it then moves into the spinal cord. And so this is where doing things like nerve blocks will actually help to mitigate or preemptively block those pain signals. So it's important that the type of block that we are actually utilizing matches the type of pain. So for your somatic or your peripheral pain, you want to use things like peripheral nerve blocks. For the mixed signals, you want to use truncal blocks like things like the ESP block or the TAP block. And then for visceral pain or stretch pain, that will be addressed with things like neuroaxial blocks like spinals. And so all of the other blocks, the TAP, the ESP, spinal, the ilioinguinal, those are definitely all in the anesthesia arsenal. The dorsal penile nerve block, I've never done one personally. I typically will defer that to you guys as our providers. And so that's something that you can think of if you have a procedure that's appropriate for a penile block. And just as a reminder, it's a really simple procedure, really doesn't even require ultrasound, just landmarks, 10 o'clock and 2 o'clock. You're injecting 5 to 10, plain local anesthetic. And again, emphasis and a reminder, again, that on bupivacaine, you really can get 12 hours, sometimes 24 hours out of bupivacaine, as opposed to lidocaine. Lidocaine is gone in an hour. So from our spinal cord sensitization, it enters into the dorsal horn of the spinal cord. And so this is where you can have pain signals that are received from the periphery that will either be ramped up, or we can work on dampening those pains. That's called central sensitization. So here it is appropriate to use opiates. It's important to know that multimodal, I will tell you, when we started to transition multimodal into our department, there was this misconception that you don't use opiates at all. And in some cases, when you have lower pain scores, it is appropriate to not necessarily use opiates. But very often the goal is to decrease your reliance and decrease the amount of opiates that we're giving, not necessarily the elimination of opiates. So opiates would be appropriate here, using things like alpha-2 agonists like clonidine and Precedex, things like ketamine and magnesium that modulate NMDA. And again, NMDA is just, it's a signal, it's a substance that will allow either your pain sensitization to ramp up, or in this case, if we're blocking, the ramp down. And then again, using local anesthetics and using things like gabapentinoids like gabapentin in these patients. So how do these things work? With your alpha-2 agonists like Precedex, they decrease substance P. So again, substance P is what actually perpetuates the pain signal. So it'll decrease that signaling. One of the benefits as well is that in larger doses, it can cause sedation, and there's some pain relief that goes along with it as well. Multiple different uses in Precedex. Precedex should probably be implemented in most, if not all, of your anesthetics. It's a really good drug. I personally use it to replace things like Versed that has more of a prolonged effect. Additional benefits of it is that we're decreasing nausea and vomiting, right? So we're getting our patients out of the recovery room sooner because there's less experience with that. It can decrease post-operative shivering as well. Again, all things that would delay our recovery and sort of this expectation to move patients or recover patients quicker. The side effects with clonidine, you would definitely see hypotension with clonidine. So that's one that you will find that's less often utilized intraoperatively. Hypotension with Precedex is very dose dependent. Most of us will not do a loading dose of 1 mic per kilo, which is where you will get hypotension and bradycardia. But in some of the doses that we're utilizing in the patients, we're able to produce reliable relaxation. And again, analgesia is a part of the component as well. One of the additional benefits that I didn't mention here is that there's a lot of evidence that's emerging in our aging patient population. We can have cognitive dysfunction after general anesthesia. And so using Precedex in that setting actually decreases the incidence of having emergent delirium or cognitive dysfunction. Ketamine and magnesium is one that I use. Magnesium, it's usually 2 grams over about 10 minutes. All of those are going to decrease that NMDA modulation. Ketamine, one of the side effects, if we use it in higher doses, the patients can become tachycardic and hypertensive, but usually in the multimodal doses that we're using, you're usually not seeing that response to it. What you may see instead are kind of increased secretions. So it wouldn't be uncommon for you to see, if we're using ketamine, to use glycopyrrolate to just sort of dry up secretions. But other than that, it's a really good drug when used in this setting. And then gabapentin, there's less utilization of gabapentin. I personally don't use it as a part of my preoperative plan in patients. I find that you have patients that are really sensitive to the sedating effects of gabapentin. So a little less reliance on that, because again, the goal is for the patients to be able to recover quickly. From the dorsal horn, the next signal that our pain response ascends to is the brain. And this is sort of where the patient has this conscious experience of pain. And so while you can increase sedation so that the patient isn't consciously aware, it's not necessarily treating the pain signal itself. So for instance, even under general anesthesia, you can have a patient that they will retract or move in response to stimulation, but they won't have awareness of it. Under general anesthesia, the concentration of volatile anesthetic or anesthesia gas that's required for the patient to have amnesia is really low, but that's not necessarily a balanced anesthetic. So again, if we're not addressing pain, all of those things that we mentioned with having that increased pain response, all of the negative sequelae that comes along with that, you have to address that as well at the level of the brain. So that's, again, where opiates would be appropriate. All of your systemic medications, acetaminophen, ketamine, and your alpha-2 agonists would be appropriate here. So in the brain, you have bidirectional signaling. So it's not just receiving pain signals. You can also have the brain sensitize the patient and increase or upregulate the patient's response to pain. So it's important, again, for us to ensure that the patient is appropriately medicated, and it's not just sedation, that we're addressing the other ways and other pathways to be able to decrease or create this descending modulation where we're down regulating the patient's conscious response and subconscious response to pain. So the bottom line, with all of the things that I have mentioned, all of these culminate into what we now describe as our ERAS protocols, the early recovery after surgery. And so utilizing things like preoperative hydration. I hope your clinics, we've certainly emphasized to the preoperative nurses at East Jefferson, but I hope for appropriate patients that don't have things like gastroparesis or severe reflux, we're hydrating the patients well in advance so that, they're able to have appropriate sedation and medication, and their vital signs, they aren't hypotensive because of the decreased systemic vascular resistance that comes from giving drugs. So doing things like culminating this ERAS protocol, you guys addressing things preoperatively before the patient comes into the operating room, your anesthesia providers, your anesthesia team, again, taking this multimodal approach to addressing the pain. And then postoperatively for you as well, being mindful of what we're prescribing for the patients, utilizing some of these other medications so that we aren't heavily relying on opiates. The ERAS protocol is sort of the bottom line for us when we're discussing, implementing, and adopting this into our practice. So for us, again, goal isn't necessarily focused on MAC or general anesthesia. For us, the goal together for should be safer care, ensuring that our patients are recovering faster, both intraoperatively and postoperatively, and then relying less on opiates, both during that acute phase and also postoperatively. So same case, better strategy for us. Any questions that I can answer for you?
I just had one. I don't know if it's a myth, but something I heard in the past was for your local anesthetic, some people will do lidocaine plus bupivacaine. And the anesthesiologist told me in the past that people think that they're getting the best of both worlds, but really they're just decreasing the ideal effect of each one. And then the other aspect of it is when the patient's already getting general anesthesia, there's really no need for the lidocaine because they're already getting anesthesia. So they just need a long-lasting effect of the bupivacaine. Can you comment on this?
Yes, so correct. When you mix the local anesthetics, you're essentially diluting the local anesthetic. So if your goal with lidocaine is rapid onset, when you are diluting it with bupivacaine or ropivacaine, you're actually decreasing the concentration. And so if you're decreasing the concentration, you're decreasing the effectiveness. And same with Marcaine or ropivacaine. If I am diluting it with lidocaine, then the concentration itself is decreasing. And so if I have a lower concentration of Marcaine, I'm going to have the block won't be as dense and it certainly won't last as long. Now, in terms of injecting local anesthetic preemptively, I don't think you lose anything by injecting local anesthetic. You don't need the rapid onset of lidocaine if the patient is under general anesthesia. I think that that's the benefit when you have a patient that's under MAC anesthesia, you're ready to make incision and you want fast onset. That's where lidocaine will benefit. And then you can follow up maybe at the end of the procedure and inject Marcaine along that incision line. But a balanced anesthetic, that's very subjective. So when we talk about MAC of anesthesia, that's the minimal alveolar concentration. That's the balanced anesthetic where the patient will not respond to surgical stimulus. We sort of start in the middle of the bell-shaped curve, right? But you're going to have some patients that will end up on the side where they need more. And so you may have a patient that still, they're under general anesthesia. We've given what we think is appropriate balanced anesthetic doses of all of the drugs. But then you make an incision and the patient still responds with tachycardia or hypertension. They aren't going to move if they're paralyzed. If they weren't paralyzed, they would move. And so I don't think you lose anything by injecting preemptively before incision. But if the patient's under general anesthesia, Marcaine might be a better selection because then you wouldn't have to re-inject at the end of the case unless you ventured somewhere beyond 8 hours. I would encourage you to inject again. And the therapeutic window for these drugs, it's really high. So it's if you're using it with epinephrine, you can use 3.5 milligrams per kilogram. Some people are conservative and will say 2.5, but 2.5 milligrams per kilogram. For the average patient, you can inject over 40 to 50 cc's of 0.25 Marcaine.
And you said to inject at the beginning and end of cases. You know, for scrotal cases especially, my experience is we usually just inject at the end. I mean, would that be beneficial for us to inject at the start of the case too, anesthesia-wise?
I think that it would be beneficial just as a preemptive anesthetic. So most of the multimodal things that we give it what we call preemptively. We try to time a number of those things pre-incision just to ramp down that signal. So for you, if you're using, again, if the patient's under general anesthesia, you can use Marcaine and you're injecting preemptively. So you are addressing pain at that nociceptive signal. Because again, some patients, they are under deep anesthesia and we're in the plane of what we call balanced anesthetic. But for some patients, again, it's a guesstimate. It's a guesstimate unless we have a patient that comes in that says that, hey, you know, I really have a high tolerance to medications. Those are the patients that we're really going to trend towards a deeper. But usually we just start in the middle and then we'll adjust it based on when you make the incision. That's when I know as an anesthesia provider, hey, do I need to give more because the patient becomes hypertensive or tachycardic? It's really a guesstimate as we're starting out. So if you're doing it preemptively, then the patient benefits.
Also, to add on to that, that's kind of like so for my penile implants, I do a pudendal block right at the beginning, and it decreases the overall need for anesthesia during the case.
Like for scrotal cases,
Yeah, so and your local anesthetic really should be before you cause your stimulation.
I have two questions. Do you have any special policy for TURBs, transreauthorization of bladder tumors, in terms of like more antispasmodics? It's always my concern when we are doing a TURB, especially if it is on the lateral, which the pudendal nerve is there. Do you usually give the patient like enough amount of antispasmodics, or we have to ask you in between the surgery always?
I would say ask. The antispasmodics are not going to be something that's innate or a part of sort of the anesthesia toolbox. It would be something that you would need to ask for because it's not included in the anesthesia Pyxis. So that's something you can order in advance. You can actually put it on your preoperative orders. Anything that you want us to give, you can order it preoperatively and then have it available and just ask your anesthesiologist for what you want.
And another question is that you mentioned dexamethasone. Still, I know some mostly private urologists, they are giving like a dexamethasone to all the stone pains, like when the patient comes to the ER with a small stone and they want to send it home with some pain meds. Some of them are like routinely give them dexamethasone. Do you think that works?
It does work. It's an anti-inflammatory, but you have to be mindful that if you give it over a prolonged period of time, then you can cause some adrenal cortical suppression. So if that's someone that later comes to the operating room, we need to know that they've been on steroids. We're usually giving it's one dose. We're giving it preemptively, and so it isn't suppressing the adrenal cortical axis. But in the patients that are on it for a prolonged period of time, just know that you're decreasing their body's ability to release cortisol naturally. So if that's someone that comes to the operating room, we may have unanticipated hypotension if someone's been on prolonged steroids and we're not aware. So in the short term dose, it's quelling that substance P signal, but over a prolonged period of time, not necessary unless you find it's appropriate.
Thank you.
Do we give dexamethasone from the ER?
No, I've never given it. No.
You do it for your.
Okay, thank you.
Yeah, we did. Oh, yeah. They give it a block. Speaking of blocks, bupivacaine versus ropivacaine. At one hospital, I use ropivacaine, and another hospital, I use bupivacaine because it didn't have ro. Is there a significant difference between the two for just my pudendal block that I should switch back to ropivacaine, or what are your thoughts on the two?
So ropivacaine has a safer cardiovascular profile. So essentially, if you injected ropivacaine versus bupivacaine intravascularly at toxic doses, and again, that's in excess of 40 cc's, if you're using the 0.2 or the 0.25 concentration, then you'll have patients that will have less of a cardiovascular response, so less of like a conduction block, less cardiovascular collapse if you're injecting them intravascularly. That said, I'm a cardiovascular anesthesiologist. I do pain blocks for all of our open bypass cases. I use Marcaine. Why do I use Marcaine? One, I'm not injecting it intravascularly. Everyone should be aspirating while you're doing blocks to ensure you are going to have some systemic uptake, but those toxic doses are the intravascular dose. I use Marcaine versus ropivacaine because it lasts a lot longer. Marcaine with epinephrine, you can get up to 24 hours of pain relief from Marcaine. And so both of them in terms of potency and pain relief, they're about equivalent, but Marcaine, you're going to get a longer half-life. So you can get 12, again, with epi up to 24 hours. With ropivacaine, you're going to see something more like around the 6-hour mark. So I endorse the Marcaine use, again, as long as you're using it safely and you're aspirating as you go along.
It's probably cheaper. So
Keisha, we've seen that there has been less cancellations lately.
Wonderful. Well, we want to be a good host to you, Dr. Thomas. So, finally, after 18 years, we've gotten it right.
It's a short time.
Dr. Thomas, what are your thoughts on like paralysis for BTs? Like, can you do a BT under MAC without paralysis?
I don't like to do it if the patient is bucking.
But like,
That's a formula for disaster.
you would recommend they always be tubed and paralyzed.
Yeah.
You go hot or they go.
Especially to continue that question, especially for
Lateral.
women,
Oh.
thin bladders, non-prosthetic obstruction, thin bladders. You don't want to get an adverse event with a bladder tumor. BPH, we see that sometimes. And we still take the scope out and wait for that. But a bladder tumor can change the whole stage of a disease. So I would not, but you can do what you want.
Just want to do what's best.
I've had cases that it feel very bad.
So
But-
I did a TURP today. I think it took them 15 minutes. They were really fast and efficient, but we tubed the patient and paralyzed. So you have to think about consider risk versus benefits. What would be the benefit of you not tubing the patient? I can emerge and extubate a patient that's under general anesthesia just as quickly as I could MAC. Dr. Thomas and I have been around for a very long time. So before the era of Sugamidex, we would probably have more consideration for not paralyzing the patient because we would have to wait for an appropriate recovery time to reverse. Now that really is not a consideration at all. I can give a full dose of rocuronium and reverse it 30 seconds later with Sugamidex. And so there really is no benefit if the risk is the patient could potentially move and perforate. And that's always a risk with MAC. Again, if paralytic is not a part of the anesthetic, it may not be at the level of consciousness that the patient experiences the pain, but their systemic nervous system, their central nervous system, you saw all those pathways, their body can still respond. And if they respond, that means movement and potential perforation. So always think about the risk versus benefit. And again, with a seasoned anesthesiologist, it shouldn't take them long to emerge. Now, we do have to, give a little bit of grace. It's an academic institution. We do have residents that sometimes take a little bit longer. But if someone's over sedated from MAC, it can take them long to emerge from MAC as well. And you guys often don't see what's going on the other side of the curtain. Often when we start with MAC, but the patients are really being stimulated and they move, sometimes the response is deep sedation, again, without the secure airways. So if you look, you'll see them jaw thrusting or nasal trumpets or oral airways. And it's because now they ventured really into deep sedation and general anesthesia without a secure airway. And then it can become more complex and higher risk for the patient.
Thank you.
The one thing that I've noticed is the underutilization of epidural and spinal. Again, there's a higher incidence of anticoagulation, so forget those. But in the healthier patients, we would love to have, less sedation, but more spinal. But now we use bigger prostate, so maybe an epidural could be utilized.
Right. So a lot of that, Dr. Thomas, it's the production pressure. And so, the footprint, certainly at East Jefferson in the recovery room, it's a small footprint. They really rely on us getting those patients in and moving them out pretty quickly. And so with a spinal, you're stuck sometimes with 3 hours of immobility. With an epidural, you're getting about at least a solid hour and a half. And so we find that we're utilizing that less because we're waiting longer for the patients to recover from the neuroaxial block than the anesthetic themselves. But there are some times where that's more appropriate. You have a patient with COPD, that relies on oxygen. And sometimes, like some of the hips, we do a lot of spinals and epidurals for the 99-year-old hips where we know they're going to have very likely cognitive dysfunction after anesthesia. So if it's someone that, you feel like it's a collaboration, it's not a hard no, just know that it's not something that we're utilizing more readily because of that sort of production pressure to turn over quickly.
Any other questions?
Just for residents, that's very underutilized. So given the spinal patients, neural intubation, extubation, stuff like that, pneumonia, it can be used.
like it's been years since I've seen any kind of spinal epidural anesthesia.
I think you're right.
I've never offered.
We did one
That's
last
fine.
year, Dr. Chester and I on a pregnant lady, we did a spinal, just 10 weeks, but. Is there a preferred anesthetic type for someone who's pregnant, I guess, that we have to do surgery for?
Is there a preferred anesthetic when they're pregnant? Those patients, we're typically not going to MAC. Those patients, very often they're lying flat, and so you have issues with the patients hypoventilating. Also, all of them become what we consider difficult airways after 14 weeks. They get swelling, their tissue becomes really friable, they bleed easily. And so you'll see there's going to be less reliance on someone being given MAC unless, again, it's really minimal or light sedation. You can, we do epidurals, spinals for, C-sections, but it's usually it's limited. There's predictable hemodynamic responses, so it can be done, but you'll find that there's less reliance on it unless you're in a setting where you're delivering. They also get aortal caval compression as well when they're lying flat, and the spinal and the epidural. It decreases the patient's systemic vascular resistance because they basically get a sympathectomy, so they lose their vascular tone. So we'll find that, unless you're delivering the baby and removing that aortal caval compression, we can sometimes run into issues where they're hypotensive. And mommy's mean arterial pressure is uterine mean arterial pressure. That's baby's mean arterial pressure. So it puts the baby at risk. Again, not hard and fast, but it's usually not going to be the first choice.
Thank you so much.
Thank you very much.
Thank you.
Welcome. Thank you. Thanks for the invitation.